Okay, let's unpack this. We're diving deep today into a condition that's, well, pretty common, but treating it, that's where things get really complex. Graves' disease.
Mm,
If you or maybe someone you know has navigated this, you know it's definitely not simple. Not one size fits all.
not at all.
The journey, the choices, all the factors influencing those decisions, it can feel pretty overwhelming.
It absolutely can.
Yeah.
And for this deep dive, we're working from a stack of material focused specifically on these therapeutic challenges and the different paths you can take with Graves.
Right. So our mission here is to try and cut through some of that complexity. We're going to look at why doctors might recommend certain treatments over others. You know, antithyroid drugs, radioiodine, surgery.
Yeah, the big three.
We'll touch on key guidelines, the ATA, ETA, break down the pros and cons of each option, and maybe most importantly, understand how individual things like eye disease, age, maybe past reactions to meds, and just what you as the patient prefer, how those things really shape the whole plan.
And just to be clear, everything we're discussing, it comes straight from this source material we were given.
Exactly. Think of this as your shortcut to understanding the thinking, the rationales, the nuances behind treating Graves based on these expert analyses, studies, case examples.
Okay, let's jump in then.
So the big picture first. This material really lays out three main ways to tackle overt Graves' hyperthyroidism, kind of the primary forks in the road, you could say.
That's right. And the guidelines, like the 2015 ATA recommendations, they're pretty clear. They state patients should be treated with either radioiodine therapy, RAI, antithyroid drugs, ATDs, or thyroidectomy surgery.
And that's a strong recommendation, right? Not just a suggestion.
Exactly. Strong recommendation based on moderate quality evidence, they say.
What's really interesting, though, is how the preference between these options seems to have, well, shifted over time,
Yeah.
globally even.
Oh, yeah.
Looking at these international surveys mentioned in the material, going back to like 1990 up through 2024, you see this evolution in whether doctors lean towards RAI or ATDs first. It's not static.
No, definitely not. And some recent survey data from 2023, it highlighted the absolute top factors driving the choice. For doctors and patients,
What were they?
the two biggest drivers: hope for a remission and avoidance of hypothyroidism. That tells you a lot about what's really front of mind when people are making these big decisions.
Okay, let's dig into the first pass then. Antithyroid drugs, ATDs. The material suggests these are actually the most common starting point in the U.S.
They are, yeah, a very frequent initial treatment. Now, if you go the ATD route, the specific drug and the starting dose, those are critical first steps.
And the guidelines have a favorite.
They strongly prefer methimazole or MMI for basically almost every patient choosing this option.
Almost every patient. So there are exceptions.
A few key ones, yeah. The material points out PTU, that's propylthiouracil, is preferred during the first trimester of pregnancy. It might also be considered in thyroid storm, though the evidence isn't super strong there for preferring it over MMI. And, very occasionally, if someone has a minor reaction to MMI and they absolutely refuse RAI or surgery, PTU could be an option, but MMI is really the default.
Got it. MMI first, usually. How do they figure out the dose to start with?
It's tailored.
Yeah.
Depends on how high the thyroid hormone levels are. The higher your free T4, generally the higher the starting MMI dose needs to be.
Makes sense.
Doses typically range from 5 up to 30 milligrams per day. For really severe cases, maybe even higher, up to 40 milligrams a day. And sometimes if it's really severe, they might split the dose because the drug doesn't always last a full 24 hours.
And what about checks? Anything absolutely essential before someone starts MMI?
Oh, definitely. Before that first pill, you absolutely need baseline blood work. A complete blood count, looking closely with the white blood cells, and liver function tests, LFTs.
Why those specifically?
Because these drugs can, though it's rare, affect your white count or your liver. So if the neutrophils, a type of white blood cell, are already really low, or if the liver enzymes are way up, the material says you've got to seriously reconsider using ATDs at all.
Okay. Let's bring in a case example from the material. We've got this 29-year-old woman, pretty classic Graves' symptoms, some mild eye stuff going on, enlarged thyroid. Her labs confirm it. High free T4, high T3, TSH is suppressed, TSI antibodies are up.
Typical picture.
After talking through the options, she picks MMI. Her free T4 is about 1.5 times the upper limit of normal based on the reference tables provided.
Right, and the material actually presents a very similar case, asking about the starting dose. In that example, with similar free T4 elevation, the answer given is 10 milligrams per day.
So that reinforces the idea that the dose matches the severity.
Exactly. 10 milligrams seems about right for that level of hyperthyroidism.
Okay, so she starts on MMI. But it's not just about the dose, is it? Managing potential side effects, making sure the patient knows what's what, that seems huge.
It's absolutely critical. Patients need to know what to watch out for. Ideally, they get written info plus reminders at every single visit.
What kind of side effects are we talking?
Yeah, there are minor ones, things like a rash, itching, maybe some stomach upset. Those can happen in maybe 1 to 5% of people with either MMI or PTU, usually in the first few weeks.
Okay, those sound manageable. What about the more serious ones?
Yeah, those are the ones you really worry about, thankfully less common. A granulocytosis, it's a dangerous drop in certain white blood cells, happens in about 0.2 to 0.5%, usually within the first, say, 90 days.
Wow, okay.
Severe liver problems can also happen, maybe a bit more commonly with PTU than MMI, but still rare.
Yeah.
Again, usually within those first 3 months. And then there are some less frequent, potentially longer-term things like drug-induced lupus or vasculitis.
So, what specific symptoms should patients absolutely be told to report, like immediately?
The list from the material is vital. Any new itchy rash, any signs of liver trouble, yellow skin or eyes, jaundice, pale stools, really dark urine. Also joint pain, bad abdominal pain, nausea, fatigue, or any signs of infection like a fever or a bad sore throat.
If any of those pop up.
Stop the drug, call the doctor right away.
Okay, let's go back to our patient, the 29-year-old. She started 10 milligram MMI. 3 weeks later, boom, swollen lips and face. No breathing trouble or hives, but definitely a reaction. MMI stopped, swelling went down with antihistamines. Now she's adamant. No RAI, no surgery. What now?
This is where things get interesting. Since it wasn't a granulocytosis or liver failure,
Yeah.
the really bad ones, the material actually points to desensitization as a potential option for these kinds of allergic reactions, like rash or swelling.
Desensitization, you mean trying the drug again carefully?
Exactly, under supervision. There's a study mentioned that showed it worked for a small group of patients, allowing them to stay on MMI despite an initial allergic-type reaction.
Huh. So it's not always game over if you react.
Not for the less severe reactions, potentially no. And in her case, let's say she was successfully desensitized. She restarts MMI, her thyroid function normalizes over 8 weeks, dose gets lowered to 5 milligrams a day, and she stays on it for 18 months.
Okay, 18 months later, labs look good, free T4 normal, TSH normal, but her TCRAP antibody level, that's another thyroid antibody, is 125%. The lab report says that's within the normal range, 0 and 49%. So
Right.
what now? Does she stop? Keep going. What does that normal antibody level really mean?
This is such a key point, and the material really digs into this. It gets at the heart of the challenge. How long do you treat, and what do these antibody levels truly tell us about the odds of staying in remission if you stop?
The guidelines do suggest checking antibodies before stopping.
Yes, the ATA guidelines recommend measuring TRAB before stopping ATDs, because normal levels do indicate a greater chance of remission. There's evidence for that.
Like studies showing relapse rates.
Exactly. One study mentioned followed patients for 18 months. If their TRAB became negative, only about 29% relapsed. But if TRAB was still positive, almost 90% relapsed. Big difference.
Okay, so negative TRAB is good, but then the material throws a curveball. It mentions other studies suggesting TSI, the stimulating antibody, might be even better at predicting relapse than TRAB. And it gets even more complex talking about how to interpret these levels.
Yes, this is the crucial insight here. For the best prediction of long-term remission, particularly after MMI, the antibody level, especially TSI, really needs to be undetectable, not just within the lab's normal range.
Wait, say that again? Undetectable, not just normal.
That's what the interpretation in the sources suggests. Those example lab reports show how wide normal ranges can be. So a TRAB of 125%, even if technically normal for that lab, might still reflect significant antibody activity. It might not actually mean a high chance of remission if you stop MMI, especially if you're aiming for that undetectable TSI level.
Wow, that's a huge distinction. A normal lab report could be kind of misleading if you're hoping for true lasting remission.
It really is.
Yeah.
And this leads to these suggested management algorithms, ways to think about it after that first 12, 18 months of MMI.
How does that work?
The idea is check TSI or TRIAB, but interpret it carefully, after that initial period. If it's genuinely undetectable or negative, okay, stopping MMI might be reasonable. But if those antibodies are still clearly present, then the options are basically continue MMI, maybe for another 12, 18 months or even longer, or move towards definitive therapy, RAI, or surgery.
And if you stop and then relapse?
Same options come back, RAI, surgery, or potentially going back on long-term MMI.
And that long-term MMI, the material presents that as a totally valid choice. If someone doesn't remit but wants to avoid RAI or surgery.
Yes, absolutely. The
Yes.
guidelines explicitly mention it. While RAI or surgery are standard options after relapse or with persistent antibodies, continuing low-dose MMI for much longer than 18 months is something to consider if the patient prefers it. And the material notes, lots of patients do choose this.
Is there proof that treating longer actually helps more people get into remission?
The material points to data suggesting yes. Significantly longer MMI treatment, we're talking 5 or even 10 years, seems to lead to much higher remission rates and lower relapse rates compared to just stopping after 18 months.
Interesting.
There are even studies comparing outcomes like weight changes or eye disease progression between patients on chronic low-dose MMI versus those who got RAI after relapsing. Different long-term profiles.
Okay, that's a really thorough look at ATDs. What about path number 2, radioiodine therapy, RAI? This one often sounds like more of a one-and-done fix.
It's often framed that way, yeah, as a definitive treatment. But the key thing with RAI, and the material really stresses this, is that becoming hypothyroid needing thyroid hormone replacement afterwards isn't just a side effect. For many experts, it's basically inevitable or even the goal of the treatment.
Right, so you trade hyperthyroidism for hypothyroidism.
Pretty much. And that means lifelong thyroid hormone pills and ongoing monitoring indefinitely.
How long does it take for the RAI to work?
The full effect isn't instant. It can take anywhere from 2 to 6 months. And while a single dose works for a lot of people, maybe around 80%, it's important for you to know it's not a guaranteed 100% cure with one shot. And there can be temporary bumps in the road, too. Some folks might briefly become hypothyroid a few months after the dose, and about 10% might actually see their hyperthyroid symptoms get worse for a bit before they get better.
Okay. What are the main cautions or concerns with RAI?
Well, number one, it's an absolute no-go during pregnancy. Cannot be used.
Right.
Outside of pregnancy, the material notes there's no solid evidence it causes infertility or birth defects later. There's been discussion about long-term cancer risk. Some studies hint at slight increases in certain cancers, but the material also cites research suggesting that overall cancer mortality probably isn't different between RAI, surgery, or long-term ATDs. But a major consideration that comes up again and again is Graves' eye disease, GO or TED. RAI has the potential to make existing eye disease worse or sometimes even trigger it in people who didn't seem to have it before.
Yikes. What puts someone at higher risk for that happening?
Key risk factors mentioned are really severe hyperthyroidism when they get treated, high levels of those stimulating antibodies, TSAB, smoking is a big one, and also not getting hypothyroidism treated quickly enough after the RAI.
Can anything be done to prevent the eye issues?
The material mentions that using steroids, like prednisone, for a few weeks around the time of RAI might help prevent worsening in those high-risk patients. But the guidelines summarized are pretty nuanced here.
Yeah, they really tailor the recommendation based on how severe the eye disease is and whether the person smokes. Like, if someone has active, moderate to severe eye disease already, the material suggests there isn't great evidence that RAI, even with steroids, is the best bet. MMI or surgery might be preferred then.
Let's look at another case example, this one about getting ready for RAI. A 65-year-old woman, hyperthyroid for months, symptoms like weight loss, palpitations, atrial fibrillation with a fast heart rate. No obvious eye issues, thyroid isn't huge, labs are high, TSI positive. She wants RAI. Question is, should she get MMI first, before the RAI dose? This case really hits on preparation. And yes, the material indicates pre-treatment with MMI should be considered for her.
Why? To make it safer.
Exactly. Because of that risk of things getting temporarily worse right after RAI. For someone older, with atrial fibrillation and significant symptoms, that flare-up could be particularly dangerous. Pre-treatment helps lower the levels first.
Makes sense. Reduce the risk before the treatment kicks in.
Right. The material even cites studies showing fewer complications, like new AFib episodes in patients who got ATD pretreatment versus those who didn't.
Any other steps around RAI, like after the dose?
Yeah, the material briefly touches on whether or when to restart MMI after the RAI dose, referencing studies that track thyroid levels in patients who did or didn't restart it about a week later. So there's some strategy involved there too.
Okay, here's another case showing a post-RAI complication. A 50-year-old woman had Graves, but developed a granulocytosis on MMI, that dangerous white cell drop. She recovered, chose RAI, guided dose, but 3 weeks later, her hyperthyroid symptoms came roaring back, labs got worse again. She also has a history of asthma. What's the immediate next step?
Right, this is that post-RAI flare-up we talked about.
Yeah.
In this situation, worsening symptoms plus asthma making rapid heart rate riskier. The material points to starting a beta blocker like propranolol right away.
Just for symptom control.
Primarily, yes.
Yeah.
To calm down the heart rate, the tremor, the anxiety, while the RAI hopefully continues to work longer term. It wouldn't be the time to jump to another treatment necessarily, but manage the immediate flare. Interestingly, the material also brings up SSKI saturated solution potassium iodide again here, not just for surgery prep.
Oh, how else?
It mentions studies suggesting that high doses of iodine, like an SSKI, can actually lower thyroid hormones and antibodies over time, maybe similar to MMI, at least in milder untreated graves.
So it could potentially be used as an initial treatment sometimes?
That's the possibility raised, maybe in specific situations like mild disease or if other drugs aren't optioned. And going back to that woman who flared after RAI, the material shows she was actually put on SSKI, and it did help control her hyperthyroidism rapidly.
Did it fix it long term?
In her case, no. Her thyroid function normalized for a bit. She ended up needing a replacement hormone, but then the hyperthyroidism came back again months later, and she needed a second dose of RAI. So it shows SSKI can be a tool, but maybe not always a permanent solution in these complex cases.
Right. So the path can definitely have twists and turns. Okay, let's move to the third main option, surgery, thyroidectomy, also aiming for a definitive fix. What's the main job of the endocrinologist when a patient chooses surgery?
According to the material, the endocrinologist's biggest role is patient preparation, getting them ready for the operating room.
How's that usually done? What's the standard prep?
The classic way is to use ATEs first to get the thyroid function back to normal euthyroid. Then, for about 7 to 10 days, right before the surgery date, they add SSKI or Lugol solution, high-dose iodine.
Why the iodine right before?
It helps make the thyroid gland less vascular, less bloody, makes the surgery technically easier and safer for the surgeon. There are other methods mentioned too, using beta blockers, sometimes with iodine, especially if the patient can't get fully euthyroid on ATDs first.
Now, surgery sounds definitive, but it's still surgery. It comes with risks, right?
Absolutely. And the material points out that thyroid surgery for Graves actually carries a higher risk of complications compared to surgery for, say, thyroid cancer.
What kind of complications?
The main ones are potential damage to the parathyroid glands, which sit right behind the thyroid and control calcium. That can lead to low calcium, hypoparathyroidism. There's risk to the nerves controlling the voice box, potentially causing hoarseness, and bleeding, leading to a hematoma in the neck, which can be serious. And a really striking point from the material is about surgeon experience, surgeon volume.
Meaning how many they do.
Yeah, a large chunk of thyroidectomies in the U.S. are done by surgeons who only do a few each year. And the risk of complications is definitely higher with lower volume surgeons. Experience really matters here.
That's, yeah, quite sobering. And the material includes a case that really drives home the potential severity, even when things seem okay at first.
Yeah, that case of the 65-year-old woman, long Graves' history, chooses surgery with a high-volume surgeon. Operation goes fine, standard discharge. But then she develops acute shortness of breath at home hours later and dies from a neck hematoma before help arrives.
Wow.
It's rare, but it's a stark reminder from the sources that serious complications, especially bleeding, can happen very suddenly, even after leaving the hospital. That immediate post-op period is critical.
Given those risks, why would someone choose surgery then? What are the main reasons?
The material lists several key indications. Patient preference is huge. Someone might just want it over and done with definitively. Maybe they're planning a pregnancy soon and don't want to deal with meds or REI effects. Other reasons include if someone just can't stick with the medication plan, non-compliance, if they have a really large goiter causing pressure symptoms, or if there's a suspicious nodule in the thyroid that needs to come out anyway, or sometimes if they need neck surgery for another reason, like hyperparathyroidism.
Like that earlier case example. The 30-year-old woman, mild eye findings, newly married, wants to start a family soon, wants definitive therapy. After hearing about RAI and surgery, she chooses surgery. How would she likely be prepped?
For someone like her, assuming no major issues with ATDs, the standard prep described seems most likely. Get her euthyroid with MMI, then add SSKI for that week or so before the operation. The classic approach.
But what about someone who can't take ATDs? Like that other case, the woman with significant eye disease who got a granulocytosis from MMI. RAI was risky due to her eyes, so she needed surgery. How do you prep her safely without ATDs?
Ah, yes, that's a key challenge the material addresses. For patients like her, with major ATD reactions or maybe severe noncompliance, the prep has to be different. The material cites studies using combinations, things like high-dose iodine solutions, Lugols, maybe glucocorticoids like dexamethasone plus beta blockers, all given for about 10 days before surgery.
So a cocktail approach when the standard isn't possible.
Exactly. It shows the preparation needs to be flexible and tailored, especially if ATDs are off the table or if there's significant active eye disease complicating things.
Okay. So we've walked through the three main paths laid out in the sources. ATDs offering that chance at drug-free remission, but needing close monitoring and maybe long-term use. RAI is a definitive option, but leading to expected hypothyroidism and having those specific considerations around eye disease. And surgery, also definitive by removal, but carrying acute surgical risks linked to surgeon experience.
It really highlights how, even with guidelines, the final decision for any one person is deeply personal. It's about balancing these different profiles, risks, benefits, long-term realities, all filtered through your own situation and what matters most to you.
So, reflecting on all this material, here's something to chew on, a question for you, the listener. We heard that patients often prioritize hope for remission and avoiding hypothyroidism. We also saw that predicting remission with ATDs might really hinge on getting those TSI antibodies truly undetectable, not just normal on a lab report. So, given that, what's the best way, based on this information, to use testing during treatment? How can we use those results most effectively to guide these critical long-term decisions and actually help patients reach the goals that they value most?
Yeah, it really pushes us to think about how we communicate these probabilities, how we use the sharpest tools we have, like maybe focusing more on undetectable TSI, and how we truly partner with patients to navigate this complex landscape and find the best individual path forward.